this is, you know, incredibly worthwhile. So, okay, we've done that. Thank you very much. Now, this month, sorry, let me just get that off my screen. This month, our topic will be alcohol. Hopefully, you have all received your module on alcohol. Don't forget the quiz that's there for you. Hopefully, you've read that reading, or you've gone further and looked at the Addiction Medicine Handbook and that chapter in there, which gives you an amazing bit of information and education to look at alcohol dependence and withdrawal, which is fantastic. What I will do now, next slide, being mindful though, going back to that, you don't need to go back, Colleen, but that last one, this presentation will run from 6:05 to 6:35. We will have a Q&A section for 10 minutes from 6:35 to 6:45. During that time, you are all going to be muted during this section A, which is an open section for anybody that wanted to join. The CCC program participants will continue in section B, which will start dead on 6:50. So in those 10 minutes for Q&A on this particular topic, please put your questions in the chat section, which is down the very bottom that you can see there. Just type in a question or raise your hands. Colleen and I will endeavour to get those questions fed to Stephen. If there's anything particular about the CCC program itself, perhaps hold off until section B or later on. Really, hopefully that your questions are more in relation to Stephen's talk. So without further ado, moving on, let me introduce our clinical expert for our first presentation, and that is Stephen Ling, nurse practitioner and credentialed drug and alcohol nurse. Stephen has been a nurse practitioner in drug and alcohol since 2004, and he was the first nurse practitioner in drug and alcohol within Australia. He has worked in consultation liaison drug and alcohol for over 25 years. He has been involved in the development of substance use in pregnancy and substance use and chronic pain clinics. Stephen has presented both nationally and internationally to audience on a range of topics related to substance use disorders, and has published on the validation of an alcohol withdrawal scale for use in general hospitals. He is an accredited prescriber of medication-assisted treatment for opioid use disorder. In 2017, Stephen was awarded the Australasian Professional Society of Alcohol and Other Drugs, APSAB, Clinician of the Year Award. He is currently on secondment to eHealth in New South Wales as a member of the real-time prescription monitoring team. Stephen, hand over to you. Thank you.
Thank you for that introduction, Darren. Hopefully everyone can hear me. And thank you, Colleen, Jason, and everyone else involved in developing the program. I'd just like to start off firstly by saying that I haven't received any funding for the presentation this evening, but I have no conflict of interest. So next slide, please. So what I'm hoping to cover this evening are introducing some of the information around alcohol itself. We'll explore a little bit around screening and assessment for alcohol use. We'll go through alcohol withdrawal, and then we'll look at alcohol use disorder treatments and medications that can be useful in managing and treating, caring for patients with alcohol use disorders. Next slide. As I'm sure everyone is aware in the audience, alcohol is a central nervous system depressant drug. It works mainly via the gamma-aminobutyric acid system, or GABA. Now, in 2019, around 79% of adult Australians had used alcohol over that 12-month period, and 15% had consumed at least 11 standard drinks at least once in the previous 12 months. I've just lost the slides there.
Sorry,
Colleen.
I'm getting phone calls and people who can't get online. It'll be one moment.
Thank you. So within that 12-month period. Now, of people seeking treatment for substance use disorders, around 34% of people seeking those treatments are doing so as a result of alcohol use. Next slide. So what is a standard drink? And I'm sure everyone in the audience is aware of this, but it's important not to assume anything. So in Australia, a standard drink equates to 10 grams of alcohol. So we're looking at 30 ml nips of spirits, a 60 ml glass of fortified wine, so ports, sherries, muscats, those sorts of things, a 100 ml glass of table wine or of sparkling wine, a 285 ml glass of cider or full strength beer, a 375 ml glass of mid-strength beer, or a 425 ml schooner of light beer. Now, those measures can vary. The concentrations of alcohol in many of these drinks can vary, and so it's important to be aware of exactly what the alcohol content of whatever drink it is that you're having at any one time actually is. Next slide, please. The alcohol guidelines for Australia, there's really no safe level of alcohol use, we now know, but for healthy adults in Australia, we recommend that a healthy adult drink no more than 10 standard drinks in a week and no more than 4 standard drinks on any one day, in a bid to reduce the harm related from alcohol. Obviously, the less you drink, the lower the risk of harm. Children and people under the age of 18 years should be advised not to drink, largely because of their developing brain. And women who are pregnant or breastfeeding should not drink as well. And I would also include in that anyone who experiences either physical or psychological problems associated with alcohol really should be advised to avoid alcohol as well. Next slide. If we look at the apparent consumption of alcohol in Australia over time, I guess the point of this slide is really to show the variations and fluctuations in alcohol use over time. It's never static. During periods of war, for example, you'll see the use of alcohol decline. Immediately following periods of war, consumption of alcohol tends to increase. Next slide, please. It's important for us all to have a bit of an understanding around what a substance use disorder might actually mean when we're discussing any of the substances that we manage in the drug and alcohol sector. If we look at a table developed by Hassan and colleagues from 2013, when comparing the DSM-4 with the DSM-5, the DSM-4 has many of the criteria that is currently covered by the ICD-10. When we look at a criteria for abuse, we're looking at one or more criteria of either hazardous use, social or interpersonal problems related to alcohol, neglecting major roles as a result of alcohol use, or having legal problems associated with alcohol. But for dependence, 3 or more criteria of withdrawal from alcohol, developing tolerance to alcohol, using the drug in larger amounts or for longer than first intended, having repeated attempts to quit or control use of drinking, spending more time than first intended using the drug, or having physical, psychological problems related to use, or giving up important activities associated with using alcohol. And DSM-5 has now sort of brought those two together. So most of the criteria are still there. Legal problems has been removed, largely because legal problems is really, it's dependent upon whichever demographic you may be in. So New South Wales will have different laws associated with drinking than Queensland, for example. It may even differ according to regions within different states. So having legal problems as a criteria for a diagnosis doesn't make a lot of sense as far as that's concerned. So the new DSM-5 has most of those criteria with a threshold of 2 or more defining a substance use disorder. Next slide, please. And if we look at the ICD-10, in addition to harmful use and dependence, there are also a number of other diagnoses that can be associated with alcohol, or in fact any of the other drugs that we deal with within the field. Now I'm showing this for the sake of for the purposes of just showing you some of the diagnoses that can be applied that are important for things such as activity-based funding. So activity-based funding will often require these diagnoses be applied in order to achieve the funding that that funding bodies are supplying. Next slide, please. So when we think about alcohol, most people will have either experienced alcohol intoxication themselves, or they certainly would have seen it in the community. So during a period of alcohol intoxication, people will become dizzy, their reflexes are slowed, they have poor balance and coordination, they have slurring of speech, they can become drowsy, they'll have impaired judgment, they can develop a headache and nausea and vomiting, they can become agitated with the development of a swinging mood, they can become quite disinhibited in their behaviour, and obviously if they drink too much, they can lose consciousness as that drowsiness increases. And in very severe cases, alcohol, being a depressant drug, can slow down respiration so that there can be a respiratory arrest, which can lead to death potentially. Next slide, please. Now, in withdrawal, patients can experience tremor, sweating, nausea and vomiting with a poor appetite. Some people can develop diarrhea. Headache is common. Patients become anxious and restless. They have an elevated temperature, heart rate, and blood pressure. And in severe cases, and these are the things we really hope to avoid in managing alcohol withdrawal, patients can experience seizures, hallucinations, and acute confusion or delirium. Now, it's really important to understand that the blood alcohol concentration does not have to reach zero for alcohol withdrawal to occur. And some patients who are very tolerant to alcohol will even start to experience alcohol withdrawal from anywhere from about 0.2% downwards. Typically, I tend to avoid treating those people acutely until they reach about 0.1%. But certainly if they have clear signs of alcohol withdrawal between 0.1 and 0.2, I will treat them, and I'll come to those sorts of treatments in time. Next slide, please. So alcohol is metabolized largely by alcohol dehydrogenase. There is some cytochrome P450 metabolism with cytochrome P452E1. Alcohol is further metabolized from acetaldehyde to acetate by aldehyde dehydrogenase, and is then excreted via the kidneys through the Krebs cycle. Next slide, please. So in terms of screening for alcohol use and alcohol use disorders, screening for unhealthy alcohol use and appropriate interventions, to my mind, should be implemented at all contacts with the healthcare system. So any patient who presents to an emergency department really should have a screening process implemented on presentation. And it can be something as simple as, do you drink or don't you drink? And if you drink alcohol, then further questions can be asked. If you don't drink alcohol, there's little point in going further. But most people will apply something like a quantity frequency measure. So how often do you drink alcohol? How much do you drink alcohol? There are a variety of screening tools, and I've deliberately avoided putting any screening tools in here this evening because there are a variety of them. There are many. I think the ones most commonly used would be the audit or the audit C, which is a 3-item scale, which can be used very quickly in emergency department settings. But we can also look at things like biological markers, and it's really important that at the nurse practitioner level, we have a very good understanding of what these biological markers mean, and an understanding that there is no single indicator which can diagnose a substance use disorder when we're looking at a biological marker. Next slide, please. So screening then should lead into a further assessment of the patient. An assessment should include things like a more comprehensive evaluation of alcohol use by the patient. We should be examining the patient for the effects of alcohol, physically and psychologically. We need to be obtaining clinical investigations. With the permission of the patient, we should be gathering collateral history. Now, we can gather some of that without the patient's permission if we have access to electronic systems. The previous presentations from the patient, for example, in an emergency department can be very useful. But in order to obtain collateral history from the patient's family or friends, we certainly need the permission from the patient. Unless, of course, they're so inebriated, so intoxicated that they can't provide permission, in which case we can obtain further history from family or friends who may be available. And we need to be considering whether they have those other alcohol-related problems that we mentioned previously, and I'll come to some of the more alcohol direct related problems shortly. Certainly, we should be considering specialist consultation if there are safety concerns for the patient, and we need to assist the patient to develop clear and mutually acceptable treatment goals and a plan with specific interventions for obtaining those goals. Next slide, please. So there are a multitude of conditions related to alcohol use. And in fact, there is probably no physical or even psychological system in the body that can't be affected by alcohol. So you will have patients presenting with acute medical presentations associated with alcohol. You'll have patients with central nervous system involvement from alcohol and neuropsychiatric conditions. They will have gastroenterological conditions or cardiovascular conditions. Hematological conditions and nutritional deficiencies are common. They will often have metabolic disorders. They can have cutaneous conditions. Malignancies are also common. Patients who drink alcohol are at risk of all head and neck cancers, for example. Fetal alcohol spectrum disorder certainly cannot be ignored in this field, but there are also those psychiatric and social conditions associated with alcohol also which cannot be ignored. Next slide, please. In terms of pathology, and I'll stick very clearly with the specific pathology that I rely on when assessing someone for alcohol use, I would be looking at a full blood count at the very least. I'll be looking at their UECs and liver function tests. I would also consider magnesium levels. Magnesium, patients who drink alcohol are often deficient in magnesium as a result of decreased oral intake, decreased absorption, and increased renal excretion. A blood glucose level can be useful. In heavier drinkers, and certainly in patients who are drinking who have deranged liver function, I would be considering an AAPT and an INR. Blood or breath alcohol concentrations, to my mind, remain underutilized, particularly in the emergency department. Certainly, if you're treating a patient for an alcohol use disorder and you're reviewing them for withdrawal daily, then I would recommend a breath alcohol if you're treating them as an outpatient and you don't have access to blood collecting facilities. And other tests can be ordered if indicated. So a bloodborne viral screen, certainly if there are other risk factors for bloodborne viral exposure, and a sexually transmitted infection screen as well. Next slide, please. So who is at risk of alcohol withdrawal? In my experience, and certainly the classifications of patients or the situations we see patients in where we see them going through alcohol withdrawal, any patient drinking around 80 to 100 grams daily on a regular basis, I would view as at risk of alcohol withdrawal. Anyone with a blood alcohol concentration of around 0.2% or greater with little obvious impairment, I would see as being a risk factor. it will take you around 100 grams of alcohol to get to 0.2. So if you're not affected by that, that would indicate that you're tolerant to that level of alcohol. For me, that you're at risk of a withdrawal syndrome. Anyone who has an acute alcohol-related disorder, I would see it as at risk, or anyone with a recent alcohol withdrawal, especially in the last 3 months. Now, intercurrent conditions causing stress to the body, particularly a recent or imminent anesthesia, general anesthetic, increases the risk of a withdrawal syndrome. Next slide, please. So the goals of management really are the prevention of severe withdrawal, so seizures, hallucinations, and delirium, reducing the risk of injury to the patient, reducing the risk of dehydration, electrolyte imbalances, and nutritional imbalances, identifying and treating concurrent medical conditions that can sometimes mask or mimic alcohol withdrawal, or as I said, any stress to the body will complicate the alcohol withdrawal process. Next slide. In choosing whether or not the patient needs to be managed as an inpatient or an outpatient, there are several things to consider. Not having a responsible support person would imply to me that I'm more interested in treating the patient as an inpatient rather than an outpatient. If the patient has an acute mental health illness, I would be more inclined to offer inpatient treatment. Certainly, if they have serious medical comorbidity, they're at greater risk of complicated withdrawal. Again, I would be looking at inpatient treatment. If they have a comorbid other substance use disorder, again, that will complicate the management of the alcohol withdrawal process, and those patients should be managed as an inpatient. Patients with a history of complicated alcohol withdrawal, I would consider loading with benzodiazepines, and I'll come to that shortly. So again, they should be managed as an inpatient, and patients who are homeless and can't really care for themselves should be offered inpatient treatment. And finally, patients who have repeated cycles of outpatient withdrawal management, particularly where you're concerned that the patient is starting to develop a dependence on benzodiazepines in addition to alcohol, certainly should be managed as an inpatient. Next slide, please. Now, something that I have only seen in one series by Aidan Foy's team, it's quite an old series now, it's 25 years old, is the timing of events. Now, I know that there are a number of different graphs and charts out there in the public domain attempting to show the timing of events in alcohol withdrawal. None of them, to my mind, have really been based on research conditions in the same way that Aidan's team managed to time events for patients at risk of alcohol withdrawal. The limitation for our discussion this evening, of course, is that these are all inpatients in a general hospital. So these were following an admission. It's far more difficult to assess the time to complications of alcohol withdrawal in an outpatient treatment group. So this is a group where the patients are in front of you, you know that they're in front of you 24 hours, you can do regular breath or blood alcohol on them, and you can certainly assess them regularly for the signs of alcohol withdrawal. And what Aidan's team were able to conclude were that complications could happen anytime from admission to hospital. So we need to remember that the patient may not have been drinking for some time before they presented to the hospital. And that can be the case for outpatient treatment as well. You cannot be certain of the patient's last drink. What they determined was that delayed assessment beyond 24 hours was the most dangerous aspect that could increase the risk of an alcohol withdrawal. So if you delay assessment, the patient is more likely to experience a complicated withdrawal. They found that 90% of seizures from alcohol withdrawal occurred within 9 hours of admission to hospital. And in fact, most of those patients presented to hospital with a seizure as their presenting problem. 90% of patients experienced hallucinations within 64 hours of admission, and 90% of delirium occurred within 85 hours of admission, so around 3.5 days. In the majority of cases, the syndrome will have resolved within 5 days of onset. Now, I would be saying that if the patient develops delirium after that 3.5 days, there's likely to be some other cause. And in fact, any patient developing delirium during alcohol withdrawal needs a full delirium workup. When you don't find anything, do it again. Next slide, please. So the procedure is to prepare the patient. So apply psychoeducation, make sure the patient is ready, they know what to expect. Patients should be monitored closely if they're an outpatient by a trustworthy family member or a friend, or reviewed regularly and closely by staff if they're an inpatient. There are a number of alcohol withdrawal severity assessment scales out there. Again, I've deliberately not put one here because there are too many to choose from. Really, I would recommend referring to your local guidelines for which scale you choose. Next slide, please. As far as the medical management of alcohol withdrawal is concerned, the benzodiazepines really do remain the gold standard of treatment for alcohol withdrawal. There can be debate around long-acting versus short-acting benzodiazepines. I prefer to use long-acting benzodiazepines. Short-acting can be useful where the patient has an acute or a chronic medical comorbidity, where a long-acting benzodiazepine may be dangerous. So decompensating liver disease, for example, or respiratory problems. There can be dose loading versus symptom-triggered therapies where patients are put on a regimen of doses of diazepam or another benzodiazepine on a regular basis. I tend to prefer those as an outpatient treatment process, keeping in mind that the administration of a benzodiazepine can cloud or complicate another acute medical presentation in a hospital setting where symptom-triggered treatment may be a preferable approach. It's important to remember that there is no long-term indication for benzodiazepines in the treatment of alcohol use disorders. And again, I would encourage you to refer to local guidelines in terms of the use of benzodiazepines. I'm happy to discuss briefly what I do in outpatient treatment settings if anyone is interested. Now, there are some very clear guidelines that I give to patients if they're an outpatient. They are not to drive during the withdrawal process or operate heavy machinery, and I instruct them that they are not to consume alcohol. They need to be reviewed daily with a breath alcohol, with at the very least general observations, but an alcohol withdrawal scale assessment is preferable. Certainly many GPs don't have access to those things, so at least general observations at the very minimum. The dispensing of diazepam should occur on a daily basis, and if there is evidence of continued alcohol use, stop.
5 minutes, Stephen.
A very quick word on thiamine and Wernicke's encephalopathy and Korsakov's. All patients being treated for alcohol withdrawal should routinely receive thiamine for prophylaxis against Wernicke's encephalopathy. Now, the classic triad of symptoms for Wernicke's are an ophthalmoplegia with or without nystagmus, having an ataxic wide-based gait with an acute confusion. Now, many years ago, we thought that patients required all three of these signs. We now recognize that any one is an indicator of potential Wernicke's encephalopathy, and those patients should be placed on high-dose thiamine as a priority. Thiamine is a cofactor in glucose metabolism. Nerve cells require glucose in order to function. Decreased thiamine levels then lead to decreased metabolized glucose, which central nervous system cells cannot use for energy, which then leads to cell death. So essentially, it's causing a form of brain damage. And in severe cases, which was once called Korsakov's, patients become amnesic, they experience deficits in explicit memory, and they develop confabulation. Now, confabulation is not that the patient is making things up. Confabulation means that the patient's brain is attempting to fill in gaps in memory for themselves, and so they are giving you the information as they can recall it, even though it's absolutely incorrect. Next slide, please. So symptomatic treatments include treatments for headache, things like paracetamol, but patient's liver function matters here. Patients can use an antacid for nausea. They can also use antiemetics, things like metoclopramide or prochlorperazine. For diarrhea, you can consider loperamide or Caomagna. And it's also important to correct electrolyte abnormalities if they're present. So if we go back to the idea of testing for magnesium levels, certainly if the patient is low in magnesium, that should be supplemented. Next slide, please. For alcohol use disorders, there are a variety of treatments. There is self-management, and I find that most patients want to try self-management first. So go away and I'll try to do it myself. And if I can't manage it, I'll come back. There are 12-step groups, things like Alcoholics Anonymous. There are other groups available now, things such as Smart Recovery. Counseling involves motivational enhancement treatment, cognitive behavioral therapy, or 12-step facilitation. And most clinicians would use a variety of these three approaches. Some patients will require residential rehabilitation support, where they go into a residential facility for 6 to 12 months in order to recover from their alcohol use before they re-enter society. And it's important to remember that family support is absolutely vital. Family members, alcohol use has a rippling effect outwards from the patient. So the family is certainly affected. Next slide, please.
1 minute, Stephen. If
we look at medications for alcohol use disorder, there are really 3 medications that are widely used. Acamprosate is a drug that assists some people with their thoughts about drinking. It doesn't work for everyone. It doesn't stop the thoughts altogether. The dose of acamprosate is by weight, 60 kilograms. Patients under 60 kilograms, the dose should be 1 tablet twice a day and 2 once a day. For patients who are over 60 kilograms, it's 2 tablets 3 times a day. Patients who are allergic or intolerant to the drug or its excipients shouldn't be prescribed the drug. People with kidney injury shouldn't be prescribed the drug. Acamprosate can cause some gastro upset early on in treatment. Usually that goes away after about a week or so. If it's prolonged, the patient may need to try another medication, and it shouldn't be used in pregnancy or lactation, and it's by authority prescription. Next slide, please. Now, naltrexone is an opioid antagonist drug. Similar to acamprosate, it seems to help some people with their thoughts about drinking. It doesn't work for everyone, and it doesn't stop the thoughts altogether. It works along a different pathway, theoretically, to acamprosate, but patients who are allergic or intolerant to the drug or its excipients shouldn't be prescribed naltrexone. Naltrexone shouldn't be prescribed for patients with severe liver damage, and it can in fact cause some liver damage in its own right. Patients who use opioids shouldn't be prescribed naltrexone because of the risk of precipitating an opioid withdrawal syndrome. It can produce depression in some patients, so that should be monitored for closely. It's not approved for pregnancy or lactation. Again, it can cause some gastro upset in the first week or so of treatment. Typically, I'd start with half a tablet, 25 milligrams, and after about a week, go to a full tablet of 50 milligrams. Again, it requires an authority prescription. And finally, the third drug that we use is disulfiram. Disulfiram shouldn't be used if the patient is allergic or intolerant to the drug or its excipients. Again, it shouldn't be used in severe liver damage. Now, disulfiram can cause severe liver damage in its own right. It can cause fulminant liver damage. So patients who are prescribed disulfiram should have their liver function monitored very carefully. It shouldn't be prescribed for patients with heart disease or high blood pressure because of the reaction that it provides. It shouldn't be prescribed for patients with a background of psychosis. If the patient continues to drink alcohol, it will cause what's become known as an aldehyde reaction. And if we go back to our slide earlier on, looking at the metabolism of alcohol, it's actually an acetaldehyde reaction where disulfiram restricts acetaldehyde's metabolism to aldehyde. So patients get a buildup of acetaldehyde, they become hot, flushed, sweaty, they develop headache, nausea, vomiting, chest pain. They feel like they're going to die if they drink while they're taking disulfiram. If they continue to drink, it's a medical emergency and they should present to an emergency department. It's not to be used during pregnancy or lactation. It costs around $80 a month. It's not available on the PBS. There have been shortages in recent years at times, but some compounding pharmacies are still able to dispense it. Next slide, please. And that's the end of the presentation for this evening. So thank you all again. I'll pass you back to Darren.
Thanks, Stephen. Much appreciated. That was a great presentation and many questions firing in and out of that chat room. And I know I couldn't get to you all, but thank you, Lucinda, for responding to many of them. I do have a few that I want to throw to you, Stephen, that may or may not have been answered. But one thing that sort of I was thinking initially when you first started talking about the DSM-4 and the DSM-5, and there's been that transition, from hospital databases, and possibly around the country utilizing the DSM-4 and that ICD coding, with activity-based funding to now more of a 5. Probably for some of the newer nurse practitioners or those that are not from drug and alcohol, you're asked in consult liaison to possibly come over and review a patient. How would you